I'm Tang. I'm a registered nurse here on the medical unit, and today I'm going to be presenting SEM scanner interventions and hospital-acquired pressure injury prevention. This is based on a capstone project that we're doing in school currently. The presentation is based around a workplace problem and finding effective interventions to combat that workplace problem. In the presentation, I will discuss 5 evidence-based practice research studies, a problem statement, a PICO statement, and a PDSA cycle. Okay, the problem statement. So the workplace problem that we're currently experiencing here at Memorial Hospital is hospital-acquired pressure injuries. Hospital-acquired pressure injuries are defined as localized pressure injuries to the skin and tissue during an inpatient hospital stay. Facility data, a recent email that Sarah sent out had discussed that there has been 7 hospital-acquired pressure injuries in 2023 so far in the medical unit. And national data displays that 2.5 million individuals in the U.S. develop a pressure injury in an acute care setting annually. By the way, hospital-acquired pressure injuries are also known as HAPIs, which they are not so happy to have, but yes. 3 negative patient outcomes related to HAPIs are they increase the patient's risk of in-hospital mortality, increase the risk of developing other hospital-acquired infections such as pneumonia, UTI, and venous thromboembolisms, and it increases the length of the patient's stay, which impacts the patient's physical and psychological well-being. Synthesis of literature. So I will discuss 5 research studies over hospital-acquired pressure injuries. Each study offers effective interventions to decrease and prevent hospital-acquired pressure injuries. The primary intervention in all of these studies is the SEM scanner. It is the subepidermal moisture scanner, and this is a picture of it. Kind of looks a little fancy. The SEM scanner is a portable, non-invasive handheld device. It assesses the development of subepidermal edema, which is caused by inflammation from an injury. It scans the projected area of the skin to detect pressure injury development, and detection approximately 5 days earlier than visual skin and tissue assessments. My first study here is implementing a new approach to pressure ulcer prevention. A study was conducted in 2020 in the United Kingdom. It included 2 district nursing bases, one in Sefton and one in South Liverpool. The purpose of the study was to determine if the implementation of the SEM scanner during standard of care HAPI prevention was effective in decreasing HAPI incident rates. The intervention of the study included implementation of SEM scanner during pressure injury prevention care. 2 groups were included. The intervention group included 17 palliative care patients, and then there was a pre-study period or a control group of a total of 230 participants. Requirements for inclusion of these participants included the Waterlow score of 10 or greater, so that is pretty much like our Braden skill assessment. So, or Braden skin assessment. Over in the UK, they use Waterlow. The patients had to have unbroken skin and had to be available for consecutive scanning for 5 to 7 days. Data that was data that was included in the collection was the Waterlow assessments, visual skin and tissue assessments, clinical interventions of SEM scanner readings, and post-study incident rates. The overall results of the study, the pre-study incident rate displayed 16.1% of pressure injuries, and during the study, the pressure injury incident rates were 11.8%. This resulted in a total reduction of community-acquired pressure injury incident by 26.8% with the implementation of the SEM scanner intervention. My second study is a subepidermal moisture biocapacitance measurement device for early detection of pressure injuries. That's a mouthful. A study was conducted in 2020 and included 12 inpatient facilities, both acute and post-acute settings. 77.8% of those settings were in the US and 22.2% were in the UK. The purpose of the study was to evaluate the effectiveness of the implementation of the SEM scanner compared to visual skin and tissue assessment and HAPI prevention. The detailed intervention that was included in this study was implementation of the SEM scanner on patients' heels and sacrum, which, as we all know, are the high-risk areas for pressure injury development, from the beginning of admission and for 6 consecutive days as standard of care HAPI prevention continued. The sample size included in the study: in the US, there was a total of 147 participants. The UK included 25 participants, and that included an overall sample size of 182 participants. Requirement for inclusion in the study, the participants could have been of any gender, and the average age of the participants was 55 or greater. Data collection that was included in this study was skin assessments as pressure injury classifications and skin characteristics, Braden risk assessment scores, SEM scanner results, and early detection rates. The overall results of the study showed that implementation of the SEM scanner was standard of care, displayed early detection of HAPIs in 87.5% of participants 7 days earlier than visual skin and tissue assessments. My third study is utility of a sensor-based technology to assist in the prevention of pressure ulcers. A study was conducted in 2018 at an acute care hospital in Canada and included inpatients from medical, stroke, and ER units. The purpose of the study was to evaluate the incorporation of SEM scanner in healthcare settings and associating interventions prompted by SEM scanner readings to decrease HAPI incidence. The detailed intervention was the implementation of SEM scanners and early detection of tissue damage and guided early intervention for HAPI prevention. This study included 2 phases. Phase 1 was a control group, which included 89 participants, and phase 2, or the intervention group, included 195 participants. And overall sample size was 284 participants. Requirements for inclusion: patients were brief, dependent, or incontinent, had a Braden score of 14 or less, and had unbroken skin. Data collection: they collected daily SEM scanner readings, Braden assessment score, and visual scan and tissue assessments. And these were all collected by using a pressure ulcer reduction program collection tool. The detailed results of the study: in phase 1 of the control group, 12 out of 89 participants developed a HAPI with an incident rate of 13.5%. In phase 2, or the intervention group, 2 out of 195 participants developed a HAPI, incident rate of 1%. Implementation of SEM scanner guided interventions resulted in 93% reduction in HAPI incidents, therefore showing that implementation of the SEM scanner was effective in reducing HAPI incident rates. I think we're on my 4th study, is that right? I lost count at this point. My 4th study is my subepidermal moisture measurement and targeted skin bundle intervention. A study was conducted in 2022. The setting was acute medical wards in a large urban acute care hospital in Dublin, Ireland. The purpose of the study was to investigate the benefits and effectiveness of SEM scanner measurements compared to visual skin assessments and standard of care alone in pressure injury prevention. The intervention was implementation of SEM scanner readings in conjunction with visual skin and tissue assessments and standard of care on patients' heels and sacral areas to guide appropriate HAPI preventative treatment. In the control group of the study, it included 71 participants. The intervention group included 78 participants with an overall sample size of 149 participants. My 5th study, oh, just kidding, we're still on this one, sorry. The requirements for inclusion of the participants included they had to be inpatient and they had to be 18 years or older. And then the mean age for the overall sample size was 66 to 68 years of age, which, I felt that was necessary to add because we have primarily geriatric patients on our unit. Data collection included SEM scanner readings, visual skin and tissue assessments, Braden scores, mobility assessments, continence status and use of barrier creams, use or absence of pressure relieving devices, such as like chair cushions, heel lift boots, sacral borders, those things. And then repositioning schedules, location of the patient when the intervention took place, so whether they were in the bed or chair. And it was recorded on site in data collection sheets. The overall results of this study showed that the control group, 1 out of 71 participants, or 1.41%, developed a visual pressure injury. In intervention group, 0 out of 70 participants, or 0%, developed a HAPI. Statistical analysis was performed using t-test. A p-value of 0.05 was displayed, showing clinical significance of the intervention. My 5th study, evaluating the impact on HAPI incidents from use of subepidermal scanning technology. A study was conducted in 2021 in London, UK, on 4 medical wards at Chelsea and Westminster Hospital. These units included medical, stroke neurology rehab, and 2 orthopedic trauma. The purpose of the study was to measure the impact of including SEM scanner technology on standard of care and HAPI prevention. The detailed intervention of the study was integrating SIM scanner into standard of care happy prevention to improve clinical treatment skills and implementing appropriate interventions based on SIM readings. The control group included 2,846 participants, and the intervention included 697 participants. The type of data that was collected in this study were types of service, so any interventions that were performed for pressure injury prevention, risk assessments, tools and care, patient demographics. Oh my gosh, I'm gonna take a drink real quick. I didn't have caffeine today.
Wet the whistle.
Happy incidents by category and SIM scanner readings. Data was collected daily with patient-specific data sheets. The overall results of this study show that the control group happy incident rates was 1.84%, so 42 out of 2,846 participants developed a pressure injury. The intervention group displayed that the happy incident rate was 0.28%, or 2 out of 697 participants developed a pressure injury. A post hoc analysis comparing prior and post-study incident rates resulted in an 81% reduction of happy incident rates across all 4 wards. This study showed clinical significance of a p-value of 0.011. My PICO statement. So my PICO statement for this project is, in adults admitted to the medical unit at Memorial Hospital, how does utilizing SIM scanner readings to guide treatment and pressure injury prevention interventions in conjunction with current practice compared to standard of care visual skin and tissue assessments affect hospital-acquired pressure injury incidents? So in the PICO statement, we have patient population. As stated, patient population was adult admitted to the medical unit at Memorial Hospital. My interventions would be the SIM scanner readings to guide treatment and prevention with current practice. Comparing to our already current practice with standard of care visual skin and tissue assessment. And the outcome is to obviously decrease happy incident rates. The current practice we have here at Memorial Hospital is visual skin and tissue assessment with standard of care happy prevention. Visual skin and tissue assessment detect damage once the damage has already reached the skin, and at that point that damage is likely to be it's likely irreversible. Damages to the tissue occur far before being detected by the human eye. Interventions, the use of the SIM scanner reading in conjunction with standard of care visual skin and tissue assessments by improving clinical decisions and treatment plans on early pressure injury prevention interventions. The use of SIM scanner readings to guide happy prevention interventions is likely to decrease incident rates. Recommendation for evidence-based practice. So I recommended that we would do a plan, do, study, act cycle, and this allows breaking down the intervention into steps and give opportunity for evaluation of the outcome while continuing overall improvement for the workplace problem. The first stage would be plan, and in that stage we would determine the outcome of the SIM scanner implementation is identified, as well as the steps of implementation. So that would be how, when, and where the SIM scanner implementation would occur. What guided interventions, such again as heel lift boots, foam borders, chair cushions, the readings would warrant, and planning strategy and data collection. In the do stage, we would implement the SIM scanner with standard of care and visual skin and tissue assessment. In the study, we would analyze the result and the data of intervention, comparing data with expected outcomes to determine effectiveness. In the act part of the cycle, the decision to adopt, alter, or eliminate the use of the SIM scanner is determined. If proven effective in the outcome, the medical unit can plan its next cycle to incorporate this intervention as current practice through Memorial. If proven ineffective, adjustment to the PDSA cycle is warranted and re-implemented. PDSA versus PICO. In comparison of these two, it allows insights into the effectiveness of the use of the SIM scanner. It allows opportunity for the implementation of the SIM scanner to be consistently reviewed and improved to allow an overall benefit for Memorial Hospital and its patient population. Methods of measuring effectiveness of the outcome. Clinical surveys will be implemented to determine if patient outcomes are improved with the SIM scanner interventions in place. And then post-presentation discussion. We can answer these questions again. Alrighty, so I'm gonna gain some feedback from you guys. We'll go through these questions and kind of discuss it, okay? Is the intervention appropriate, feasible for the workplace? Discuss rationale and suggest changes.
I'm so curious if that product is in the US. Were all of the studies outside
No.
US? No, some were
No,
US.
one study showed that even majority of the settings were in the US.
Got it.
Where I did clinical during nursing school, we used these. I remember them.
Did the bedside nurses use them, or did like the
I
wound
think
care
the beds
nurses do
both
it?
could.
Both could.
Yeah, and you just like ran the skin over. It was really beneficial.
Like they just had one on every unit.
I think that was
Okay.
yeah. Have you ever heard of a vein finder too? It's
Yeah.
Kind of like that. It was you just kind of kept on the unit. And you just
Okay.
went in.
And you just covered a localized spot of skin?
I think so. Or you could do like their whole
Your
when
high
you do your
risk
assessment.
areas,
you would just,
yeah.
I mean like your
Prominences.
elbows and you know.
And do they had some of these at a more recent conference that I went to? And Suzanne was with me and she took a lot of information on it. I don't know that she's done anything with it, but I think my question is, I love the idea of it,
Mhm.
and it's gonna help show that there's something forthcoming, but does that alter treatment plan in the sense of what did they do after they did it? Meaning, we should already be turning our patients, we should already
Right.
be doing heel with boots, so what was the additional like interventions that they put into place to maybe help prevent them from opening up or coming? Because if it's showing that they're already starting, like what else did they do? Because regardless if we have this tool or not,
Mhm.
we should be doing all of the things to
Yes.
help.
What I took from the
Prevent.
studies was like a general sense of like patient population, whether they had already, like if they had developed a pressure injury, they were excluded. They could not have a pressure injury, unbroken skin, nothing along the lines
Right.
of that. They just had to be in a high risk population.
Right.
And I think they just took from what I gathered from the study, it was like a group of patients that they scanned every single one daily.
Right.
If that's feasible in the workplace setting, I don't necessarily know. I mean, it was a study to show. They tracked the percentages of the accumulation of the subepidermal moisture to show if a pressure injury was beginning. So that is kind of what I gathered from there.
So it gave them more of a proactive,
So they could get an
Early
early, like a
ID.
head start to preventing. Instead of being like, wow, there's a pressure injury visible, we already have damage, it's likely irreversible, now we're gonna implement preventative of making it worse. This is like the head start of prevention.
Yeah, I think like in a nursing home setting makes total
Right.
sense too, because of the longevity of the
Right.
resident
I was
being
concerned
there.
about
Like the hospice
yeah.
one makes sense for hospice units that might have people for prolonged, not that it would not be beneficial in an acute care setting, not saying that at all, but
Right.
I mean, sometimes our patients are in and out 24 hours,
Right.
so we don't have quite the same,
My
but
concern
that doesn't take away
yeah.
the need for
Mhm.
the preventative interventions we're already putting into
Right.
place, you know what I mean?
The studies were saying.
It would be
you know,
neat to see. I would love to
I
see
know,
it and
it's
to
so
see
cool.
like what, like give me a fake patient that we can do a fake wound so we're not causing damage, but I wanna
Right.
see the progression and see
You just
how
volunteered
accurate.
yourself.
Yeah.
No, I said fake.
show the booty.
But no, I agree with you. I think that that's a barrier because the studies even mentioned, 5 to 7 consecutive days of scanning. How
Yeah.
realistic is that for our patients? Because our turnover rate's so quick.
Yeah.
So, all right. Anybody else have
Interesting, though.
anything else to add? All right. How will the intervention positively and or negatively impact the nurse's obligation to provide holistic, culturally sensitive, and patient-centered care to identify medical patients?
I mean, it would be very specific to the patient since you're
Yeah.
scanning them.
Right.
So you're tailoring what you're doing specifically for their areas.
It definitely provides a lot more direct care, patient-centered direct care. Okay. Anybody else have anything else, or we did all that one? Okay. What are the legal and ethical implications for nurses who will be implementing the intervention, such as allocating resources to implement the intervention and staff education?
Where did they put that information? After they scan the patients, does that go into the chart, or is that just for like our use? Where do they chart that? Is it in the chart and then cause then it's there? You know what I'm saying?
Right, and I know like through the studies, they had like their data collection tools where they put the values every day to track, and then it would warrant specific interventions. So like here, I don't know if that would be something that would be in like a skin assessment or like what type of documentation thing. I know that there had to be a lot of consent signed because it was kind of like not a procedure, but it was
Mhm.
a test with a device and a lot of information, so I don't know if that's, I know we talked earlier about like the policies and procedures and those types of things, so.
Yeah. If you have them and your policy states you're gonna use them, I mean, that would be the only negative thing, like if someone chose
Didn't.
not to do that for
Right.
whatever reason, like that would be concerning to me, obviously, but, there's ways to monitor it and, have policies to support, like we talked about, and I mean, I
We're-
think it could be beneficial.
We're forever looking at different ways to add on screenings and tools, and it's just another add-on that could potentially identify risk. And I think we look at that with all sorts of different things,
Right.
whether it be falls or skin or sepsis or, you know, the list goes on and on.
Right. How will implementing the intervention positively and or negatively impact the interprofessional and multidisciplinary teams such as workload, job satisfaction, ability to provide safe care, and the ability to participate in evidence-based practice?
I think cost would be a factor. And that would have to be negated somehow or supported somehow.
Yeah, I mean, professional, multidisciplinary, we have a wound care team, so I think it would be another tool, like we discussed, just to help. You know, our wound care team is, not robust, so sometimes having additional tools for our, bedside nurses to be able to use to see and to, find things or whatever it might be is kind of nice. It could put more workload on the patient depending on how quickly the result of the SEM scanner is. I don't know how long. Do I have to hold it here? Do I just go, you know, scan and it's, so I don't know what that would look like, on a medical floor, but, yeah.
And did they focus on specific parts of the body for most of the studies,
A
like
lot of them were like-
sacral
Yeah.
things that
Sacral
would be in
or
that
bony
region?
proximities and like the heels and sacral area.
And
Okay,
the
I
one
wondered if
said
they
they
did
had to be
extremity.
continent or incontinent, which I forget what it
I
said, but
think it
one
said
of the
incontinent.
studies had to
They
have
wanted to have a higher
incontinence,
risk group of
Yeah.
population.
yeah.
Some hospitals do the bottoms out campaign,
Mhm.
which like briefs are not allowed. So I was
Yeah.
curious if that would be more
Mhm.
useful with patients in briefs, because the content of
Right.
moisture or whatever would be
Yeah.
higher.
That wasn't kind of included in the study. I think they wanted that because I know like the first part in the control group was just an array of people. The second one, they couldn't, because of internal logistics or whatever, transfer over, that to get a new set of patient population. And the intervention group was actually higher risk than the control. So I think they included that to show like the effectiveness of the intervention. But yes, you're right. I mean, there's a lot of different factors that go into it. I know workload is a big thing, and if it has to be something that's consecutive, I mean, you know, you have to be able to ensure that everybody can maintain that if it's, you know, on the floor with nurses, because it gets crazy up here sometimes, you know?
Well, and then like, I think, I don't know what the study said, but if they were saying they have to be available for 5 to 7 days, did they scan them once a day? Did they scan them multiple
It
times?
was daily, once a day.
Yeah.
It would be interesting to scan people like upon admission, and then we could show improvement.
Yeah, that would be cool.
And, you know, our quality measures, how that impacts patients, so just a flip side of that.
Yeah. What is the workplace process for implementing the interventions, such as using evidence-based practice model, PDSA cycle, for implementing, or for quality improvement project? I know we've used all of these here, so, I mean,
Typically, a new process or something, an idea, comes from staff or a leader. It's taken to unit-based councils. They do some work. They elicit the help of evidence-based practice council, who will do lit searches.
And EVP's model of choice is Johns Hopkins. We follow that template at Memorial.
And then there are other key stakeholders that would get involved. In this case, we have a wound care team that you would ask for assistance and guidance, along with our nurse practice council, which has representation from all units within the hospital. So typically you do that kind of thing whenever it's maybe a hospital-wide implementation or change of practice, whatever it might be. So.
What are the barriers to implementing the intervention? How can these barriers be overcome?
Definitely the cost.
Yeah.
A barrier, the
Mhm.
cost and the workload of the nurses already.
Yeah.
So again, we would
I
have to
think-
have champions and people to really be gung ho about that.
Yeah, education on effective use of it, having to
Yeah.
learn how to scan appropriately to get accurate results.
Yeah, and the importance of it, you could get creative with the price. We have a healthy foundation, so that could be taken there because it would be beneficial for the patient, so that's something that could be looked at. Depending, I have no idea what they cost, but could be an option.
Anybody else have anything? And final question, who are the advocates to involve in implementing the intervention? What are these people advocates? I know like we previously discussed wound care, and I know everybody's an advocate to the patient. I mean, this is patient-centered care, it's direct care. I think it's something that,